Good evening, guys. Dani Williamson Wellness, and this is Dr. Tara Allen on here from Female Urology Nashville group. I am so excited to have her on here tonight. You guys know, as soon as you get logged on, hit your heart buttons, hit your like buttons, tell us where you're from, and put your questions up there for Dr. Allen. And we are here, it's Sunday night. So Sunday night, I told her, I said, get your wine out there and go cheers. Sunday night. So Dr. Allen, I'm going to tell you a little bit about her, and I'm going to give you some statistics on bladder health and things like that while you guys are getting on. Dr. Allen actually spoke, she and her two partners, Dr. Abel and Dr. Scarpero. I never can say it right. Scarpero. Okay.
You got it.
Spoke to Middle Tennessee advanced practice nurses a couple of weeks ago, and one of the groups that I belong to, and they were so unbelievably entertaining, and it was fabulous. And I reached out to her, and she said, absolutely, I'll do it. So I'm thrilled to death and honored that you're here tonight, Dr. Allen. But I want to give you guys a little bit of a couple of statistics here. Do you know that bladder diseases and conditions cost $70 billion annually to the healthcare world out there? There's more than 33 million adults in the United States who have overactive bladder. Nursing home admissions are estimated to cost $6 billion with a B annually due to urinary incontinence. What? That's unbelievable. 1/3 of Americans age 40 and older report having some level of urinary incontinence, at least sometimes. I bet that's even more than that, though. That's a third that report that, but I bet it's more. Do you know that 80% of Americans with multiple sclerosis report bladder symptoms? My best friend has multiple sclerosis, and that's true. Urinary tract infections cause more than 8 million provider visits annually. Of those, 5.3 million of those are from women. Isn't that incredible? Over 25 million adult Americans experience temporary or chronic urinary incontinence. Interstitial cystitis is estimated. It's estimated that 3.3 million women suffer from IC, which is also known as painful bladder syndrome. And that's a hard one. I have several patients with interstitial cystitis, and that's a really difficult one to treat. Incontinence. Women experience when they experience the involuntary loss of urine control two times more than men, twice as much as men do. And 1 in 3 women experience stress incontinence, which is, of course, the involuntary leaking. That's what I do. I don't take a HIIT class, a cardio class, none of that, because I pee all over myself. So I know that I'm not alone in this, by the way. I'm getting older. I'm not getting any younger, and I can't wait to have her teach about this tonight. But first, we're going to give you a little bit of information about her. You guys are logged on. There's all kinds of people here, from Florida to Clarksville to my mom's assisted living is watching tonight. My mom is in assisted living, and they're watching tonight. Hey, Paige. Hey, Mom. Hey, Mom. But Dr. Allen, she is a Mississippi girl. She went to undergrad in Mississippi and medical school in Mississippi. And then she did her residency in urology in Arkansas at the University of Arkansas in Little Rock. She's board certified by the American Board of Urology, as well as female pelvic medicine and reconstructive surgery. Fascinating to me. Her scope of practice is general urology with a focus in female urologic issues and sexual health. She was drawn to Nashville because of the low number of female urologists in this area. Is that right?
That's correct.
Okay. Yes. Yeah. So she offers laparoscopy, robotic surgery, treatment of pelvic floor prolapse and urinary leakage, neuromodulation for bladder dysfunction, Botox bladder treatments, vaginal reconstruction, all kinds of things. Kidney stones. You know, that's something we don't talk about enough either. Mm-hmm. Kidney stones. She was the chief of urology at TriStar Centennial Medical Center, as well as on their board of directors until 2017. Her list goes on and on and on, but we're going to get into this. Thank you for being here tonight. And I can't wait to hear what you have to say tonight. So guys, show her some love. There's already all kinds of questions up here going on right
Oh,
now.
I love
So
it.
talk to us. Tell us why. Tell us about Female Urology, right, of Nashville, because how you guys came together. And you guys, they're the only all-female owned urology group in the United States, correct?
Well, there's a little bit of a caveat to that. We're the only all-female group that only treats females. There are a few only female groups that still see a general urology population. So we're the only one
Oh,
dedicated to us girls.
okay, fantastic. Well, tell us about your group. Tell us what you do. Tell us why you're different. Let's break it down tonight and talk
Well,
about all the things.
thank you so much for having me. I feel honored for you to open me up to your family. The When we first started thinking about Female Urology of Nashville, the conversation actually started many years ago, and it was out of a little bit of frustration for the general urology groups not really knowing how to handle us. And what I mean by that, we wanted the females to ourselves, and we wanted them to keep all the prostates they could care boys, and I wanted to keep the women. And in the bigger group in town, which Dr. Abel and I were a part of for the last few years before we joined this group, they just couldn't figure that one out because there were still a lot of males who wanted to dabble in female urology, even though it wasn't their subspecialty of urology. So we decided to branch off along with so Dr. Marcy Abel, who was at Urology Associates for many years, and I'm sure there's going to be a lot of her patients online. Dr. Harriet Scarpiro has actually been in the Nashville area for many years as well. I think we're pushing 20 now because she was at Vanderbilt doing fellowship and then also taught there for many years before she decided to go out into private practice. All three of us are focused on just women. And so when we decided to join forces and start a practice just for women, it was really to make sure women knew where to go. And so we do general urology. We do everything from, vaginal rejuvenation to kidney cancers and bladder cancers and what have you. So we have a very broad scope of practice, which keeps our days very interesting.
Yeah.
But we absolutely love catering to women. And when you walk into our office, I hope I don't want you guys to need us, but if you do need us, I can't wait for you to see our office. We're so proud of it. It's very girly, nothing like any general urology office you've ever been in for sure. It looks more like just a someone's home, honestly. So you come in and visit us, and hopefully get all of your needs seen too.
Wow. Fantastic. Yeah, I've heard amazing things about it. I have several patients who come see you all, and I've never heard anything negative at all. I've never been to a urologist, at all, but I'm at the age to where I need a urologist, right? I mean, there's some things that need tweaking around there. And I know that these are some questions that people have. They're actually asking about kidney stones right now, which was
Okay.
not on the top of my list today. Well, as she says, let's talk about kidney stones, how to avoid having them again, Liz asked.
So I'm so sorry, Liz, that you've had to deal with that. That is truly one of the worst pains you can experience. I've had numerous women who have had natural childbirth tell me birthing a stone is way worse. So I can
Oh,
totally understand wanting to avoid that. The statistics are 50% of people who have a stone will have another one in 5 years. That means 50% won't as well. So your goal is to stay in that category who does not have another stone. Your best way of doing that is to stay very well hydrated. Uh, the general rule of thumb is about 3 liters of water a day for stone formers. As far as letting your urine talk to you, if you're out working outside or running a marathon and you drink only 3 liters of urine, your urine will, or excuse me, 3 liters of water. Don't drink urine. I don't care what they say on the movies, but 3 liters of water, your urine will be very concentrated. So that will tell you to drink more, but stay hydrated. As far as the hearing about holistic things that help, lemon does help. Lemon alkalinizes our body and it decreases your risk of stones. Weirdly enough, people think that they should avoid calcium, But in all reality, it's salt that you should avoid, because salt is the bus driver that drives calcium into your urine. And
Yes.
we all, especially perimenopausal and postmenopausal, we have to focus on our calcium intake. We want to have a good, solid calcium intake in our diet, but I do not want you on a calcium supplement. And I know that seems like sacrilege.
No, thank you so much. Do you know, we have a supplement store in our office. I don't even sell calcium, and people
Oh,
come
I
in
love you.
to buy calcium, and I'm like, no, you don't want calcium.
No.
Okay, thank you. And can you share with them, because I think sometimes they think I've lost my mind over things. Why wouldn't they want to take calcium? Well, why wouldn't you? My doctor said I need calcium. I have osteoporosis. I have osteopenia. I need calcium. Why wouldn't you?
Well, we do need calcium. Again, the food,
Yes.
when you get it in your food, it is bioavailable and your body is able to handle it appropriately, and it doesn't sequester it out. When you're taking a supplement, the kidneys
Yes.
say, "Oh, this is waste, and we're going to excrete this into your urine, and we're going to make a stone eventually." So
Yes.
it does increase your risk of kidney stones. We also know it increases your risk of coronary artery disease.
You
So
bet it does.
heart attacks.
Calcium builds up
Nobody
in
will.
the arteries. It does. And which is why I recommend vitamin K27 to help pull calcium out of the arteries and lay it down on the bones and make it stronger. I had no idea. I love her. I'm going to see her. I don't even need a urologist. I'm going to see Dr. Allen right now. I need you as my primary care doctor. Oh my goodness. Okay, so lemon. I didn't know that. No salt. 3 liters of urine. Crap.
Yeah.
3 liters. I wrote urine down.
Well, I
3
said
liters
it.
of water a day.
And I do get asked
Oh,
a lot, well, what about alcohol? Does alcohol increase your risk of stones? Well, weirdly enough, it's kind of paradoxical. You may think a chronic usage of alcohol and drinking that and not drinking enough water will give you a constant kind of state of dehydration, which will increase your risk of stones. But you may have heard the old wives' tale, and it's not actually an old wives' tale, of doctors telling patients to drink a beer or two to stones, because what it does is it inhibits this hormone in our body called antidiuretic hormone. So you end up making a whole lot of urine at one time, and that just pushes that stone on through. So when they tell you to drink out to help pass a stone, it's not chronically to prevent a stone. It's when you're passing, a few beers might help you.
okay. Well, I learned something new. Well, all right. We started right off with beer and kidneys and kidney stones. What about urinary incontinence? You know, this is what I see. That's what I said. I had 2 children naturally back to back 23 and 24 years ago, and I never did recover completely. Do you see that?
Oh my goodness. I've built a career around it. That's probably our main diagnosis that we treat.
Well,
We
let's
see
talk
it
about it. Let's talk about it because
all the. So as far as you read some pretty alarming statistics as far as the number of people who actually have incontinence. What's even more terrible to me is only 1 to 2% of people actually seek care for incontinence. So there are, and it depends on which studies you look at, but really, I've never seen a study that shows more than 5% of people actually address it with their physicians. So the thing about it is, almost everyone is leaking out there. Like, that's how you have to think about it. Don't be embarrassed to bring it up to your doctor. If your insurance plan needs a referral, you may have to bring it up to them for that reason. Our group does not require referrals. If you have a leaky bladder and you just want to come straight to us, just call the office for an appointment. But it is extremely common. And we used to always say, well, I do my Kegel exercises. I learned my Kegels right out of, as soon as I delivered my baby, that wonderful nurse taught me how to do Kegel exercises to get my muscles into good shape. And that is, I'm not going to knock Kegels by any stretch of the imagination. It is important to keep your pelvic floor muscles in good shape. The fact of the matter is, it's not just muscles down there. We have connective tissue and we have skin that plays a role in continence. So one thing people will see, they may do great. They may have their babies. Yeah, maybe they leaked a little bit during pregnancy, but then they did their Kegel exercises, they got dry, and they were happy as a lark until they get into that perimenopausal period. And so when we start seeing those low estrogen changes of the vaginal skin, it also can result in stress incontinence as well as urge incontinence, really strong urges. Oh my gosh, I got to get there right now. Those types of leaks can be brought on with that lack of estrogen in the vaginal skin. Now, the one of my favorite things that we use to type of leakage is actually an office procedure. When it's mild, sometimes the Mona Lisa laser, which helps with vaginal atrophy, can also help with urinary urgency and can help with leakage as well. And I'm saying when it's mild, if you have a 4 pad per day issue, it's not going to fix that. But if it's I don't yet wear pads, it's just, I'm glad my underwear has that cotton panel, we might see some improvement there. But some women don't even get that wonderful period of after kids without leakage. There are some women who straight as soon as they deliver their first child will have problems with leakage. Well, what do we do about those folks? We do encourage Kegel exercises, and we do have another procedure in the office called the Votiva or Forma V that can improve collagen in that area. But we don't typically recommend operating until you are done having babies. So once you're finished having babies, then we can start thinking about what we call the gold standard of stress urinary incontinence, which is a sling. Now, everyone has probably heard of a sling. You've probably had friends to have a sling, moms, girlfriends. Um, it, Slings are truly the gold standard for stress urinary incontinence, and slings are not to be feared. I know that there was a big campaign by all of the attorneys across the world as far as anti-mesh propaganda. Mesh is bad. You should never let anybody put mesh in your vagina. I want to strangle every one of them. Mesh was a wonderful thing for us, and until some of it got pulled off the market just because they couldn't handle all of the lawsuits. All of that issue was related to mesh as in regards to prolapse repair. They have never even dared to touch mesh for slings. We are still putting it in, and I can take someone who has a 4 pad per day problem. I can do a 10-minute procedure in the operating room and put a little piece of mesh about that big just underneath the urethra, anchoring to each side of the pelvis in the obturator internus muscle. Little incision about that big, and you can walk out of there that day with a dramatic decrease in your leakage, if not resolution of it. It's called the Solix sling, Solyx. And what I love about it is that it is anchored. And so because it's anchored, I don't have to stress out as much about you going home and picking up your 3-year-old daughter or granddaughter, or I don't have to worry about you going for a run the next day. It's really a minimal downtime. The main restriction is just no sexual activity for about 4 weeks while that incision heals. But otherwise, people can really get back to life very quickly. That's more for stress incontinence, though. So what about urge incontinence? I know I mentioned the Mona Lisa as it relates to aging, but we do have an algorithm of treating urge urinary incontinence that starts with lifestyle modification. Don't drink a lot of caffeine and alcohol. I mean, both of them can contribute. They're both triggers for the bladder. And we also know that foods that are very acidic and foods that are very spicy can be bladder triggers as well. So if you're noticing that, hey, I eat way, and so really the only way to know is to cut either or not it annoys your bladder. We also recommend strengthening your pelvic floor muscles, but what you have to remember with urge incontinence is some people actually have too tight of pelvic floor muscles, and we don't want them doing Kegel exercises. So it's hard to know whether or not you're one of those people without an exam, but a good indicator if you're having any pain with sex, or if you're if you notice that stressful situations make you pee more often, then you're probably one of those people with a lot of tension in your pelvic floor muscles, and Kegel exercises are not the answer. And we would likely get you in with this wonderful group of gals called the pelvic floor physical therapists. And people look at me very confused whenever I imply that there's a physical therapist that focuses just on the pelvis. But these gals do an amazing job at educating you on what it feels like to relax those muscles. A lot of people don't even realize because they stay so tense. So that's the first line of therapy. Second line of urgent therapy for urgent continence would be medications. Um, I'm just going to be honest with you. I don't love this group of medicines. I don't
Yeah.
love any chronic medicines. I like to. I guess the reason I probably became a surgeon is because I like to fix stuff, and so with the medicines, I just feel like I'm throwing a pill bottle at you that if you don't take it, you don't get resolution. It's you got to
Mhm.
take it every day, and for some people, it's a godsend. Say they don't have the option for other procedures, but the fact of the matter is the older class of medicines, dry mouth, dry eyes, and constipation are common. The newer medication called Mirbetriq is some people will have a little bit of a rise in their blood pressure or headaches with it. But the fact of the matter is the medicines aren't as good as our third line therapy. So I don't perseverate over those medications. If you don't like anything about them, I do not force you to stay on them. So then what's our third line therapy? Botox. That's everybody loves to talk about Botox. So then they look when I mention it in the office, then they say, "Where are you putting the Botox?" And yes, I am putting it in your bladder muscle. So it is we inject it directly into the wall of the bladder and 15 different spots and what it does is just relaxes the bladder muscle. Now, for some people it is almost too effective. So there is a risk, a tiny risk. It's only
Uh-oh.
uh,
Wait, wait,
am I
wait, you
here?
froze up on us
Okay.
for a second. It
Uh,
ended at
okay.
a tiny risk, and then
Yes. There's a tiny risk of not emptying your bladder out completely. And so in those people, about 1 out of 20 people will have a hard time emptying their bladder after Botox and have to use a catheter until it wears off enough. And it does wear off. We have to repeat it every 6 to 9 months.
Mhm.
There are other folks who have a slight increased risk of infections with Botox, and it's related to retaining a little bit of urine behind. But I routinely have people say, "I love my bladder Botox. This stuff is amazing." We also have a little, it's almost like acupuncture, but it's a charged acupuncture that essentially we do in the office. The main drawbacks to it, we put this truly looks just like an acupuncture needle. Weirdly enough, we put it behind the inside of your ankle. And we are stimulating the tibial nerve. The tibial nerve acts like an extension cord to our bladder nerves. So we can put
Mhm.
this little acupuncture needle in and we can stimulate it for 30 minutes and it's just as effective as getting on medications on a regular basis. Now, yeah,
I
isn't
get
that cool?
acupuncture almost every Monday. I'm going to talk to him about that. Of course, I've never talked to him about urinary incontinence, so
So talk to
okay.
him about tibial nerve stimulation.
No, he'll know. Yeah, he
Yeah.
he will definitely know. Okay, keep talking. Sorry, I didn't mean to
Okay.
interrupt.
No, that's fine. And it's a little bit of a tweak to acupuncture in that we are actually sending electricity through that needle. It's not just placement of the needles.
Oh, you've got a
So
little
it's
spin on it.
yeah, it's electrical stimulation for 30 minutes and then they have to come to our office to do it. I don't use this treatment a whole lot. And the reason why is only because of convenience. They have to come to our office to do it. So the initial treatment is weekly for 12 weeks, and then once a month after that to maintain the results. And if your insurance covers it, it's a cumbersome load of appointments. And so I look forward to the new technologies that are coming out where we actually have a small implantable, almost coin-like battery that does the same exact thing. So that will be so much more convenient. But probably what I would consider the gold standard, which has it's not necessarily been deemed the gold standard, there is a product called Axonics, Axonics, which is a tiny little pacemaker for the bladder, for lack of a better word. It's about the size of an Andes mint. And if when we have tried lifestyle modifications and we have tried at least two medications, then again, this treatment can actually be life altering as well, just like Botox says. We put a little lead in next to the nerves of your bladder, And the great thing about this treatment is not only does it address bladder dysfunction, it also addresses rectal dysfunction. So it's also indicated for fecal incontinence and fecal urgency. So we can put it in to help your bladder empty better. We can put it in to make you not pee as frequently and to not pee as urgently. It just normalizes the communication between the brain and the bladder. So it's really cool technology.
Okay, I have a question because I have a mother who has been diagnosed with dementia, probably Alzheimer's. She was completely continent. She's only 76 until March, until COVID. She's in an assisted living, and now she's incontinent. I mean, so we wear, I have Depends and all that. Is there anything? And her primary care doctor started her on medicine. It hasn't helped at all. By the way, nothing. So I plan on asking to come off of that. Is there anything that we can do for someone with memory loss? I mean, and so now she's having a hard time walking. I mean, I know this is a worldwide problem for these patients.
It absolutely is. And those are some of the toughest patients to treat, because then we start dealing with something called functional incontinence, where they may not quite remember to go to the bathroom.
That's right.
They sit there for hours, and then all of a sudden they stand up and it gushes out.
It gushes out. That just, yes.
And so obviously prompted voiding, having someone around that could tell them, hey, it might be a good idea to go to the bathroom. That can help. Some of the medications are very helpful, but the older class of medicine, the anticholinergics, have been shown to hasten the onset of dementia. So I really avoid them in my dementia patients.
Yes.
And I preferentially go with Myrbetriq. Myrbetriq is a beta-3 agonist, so it's a lot safer for the brain than some of the other medications. If she's not seen any improvement with that, we do see some improvement for some people with that, the acupuncture concept that I was talking about. It is posterior tibial nerve stimulation is a fancy name for that. And it's tough as far as Botox goes. We do see improvement in anyone. I mean, so really she has all of these options. It's somewhat irrelevant that she has dementia. Where we take that into consideration is when we take her to the operating room to put in that little pacemaker. We're a little resistant to full anesthesia.
That's exactly right.
So we kind of try to everything at first that we can without anesthesia before we go down that path. And we actually are doing Botox in the office, so she might be a candidate for that.
Well, we may try that. And I know I'm not the only one listening here who has a mother going through this, and it's just so heartbreaking, and yeah, it is. All right. So Rhonda says, can you speak about an old-fashioned way to deal with incontinence? The pessary. That's right. I haven't thought about it in a long time. The first time because I'm a nurse midwife, but I don't practice nurse midwifery. I've got a pessary story. Because you have to fit them for that and all that stuff. Anyway, we had to practice on each other, by the way, in nurse practitioners. In nurse midwifery school. I got that thing lubed up to measure it, put it like that, and that I lost. It flew all the way across the room. My patient, which was another nurse midwifery student, up in the stirrups, right? And I was like, uh-oh. It was funny. But the pessary. So let's talk. Do people still use them?
So, I use them more often in situations where there is concurrent prolapse. So what is prolapse? Let me just quick definition. Think of the vagina like a sock. And when that sock tries to turn inside out, that is prolapse. It's that simple. People think it's mysterious. They think, oh my God, I've got a mass down there. Nope, things are just turning inside out. And it has to do with gravity and childbirth and aging and loss of muscle mass and all sorts of good stuff. But the nice thing about a pessary is it is a space occupying device that will go into the vagina, fit somewhat behind the pubic bone, and help to keep everything in place. Now, what I find is there are just better solutions for stress incontinence than a pessary. And the pessary is not going to be that beneficial for urge incontinence. So I rarely try it for stress incontinence. if they are elderly and they have severe stress incontinence, we'll give a trial of it. But so many people just don't like the feeling of something in there all the time. And the main people that it's most beneficial for, the elderly, they have severe vaginal atrophy a lot of times, and that pessary will cause ulcers. And it's just not the most straightforward way to treat stress incontinence. And you're exactly right. It's old fashioned. And so if it's what a patient wants, I have no problem trying it. But it's most common that they come back to me and say, well, tell me what else you got.
Wow. Yeah. Yeah. I don't. Okay. Which has the less side effects, Botox or the unit under the skin for overactive bladder?
Good question. So I touched on this a little bit already, but the Botox does have more side effects, or more potential for side effects. The unit.
Whoops. Where'd she go? Oh my goodness. I don't know where she went. All right, guys, post your questions up there because, and so we'll finish talking about urinary incontinence. Then we'll probably talk about overactive, underactive bladder, chronic urinary tract infections. So whatever you guys want to talk about, put this up there. Oh, here she comes again. Let me get you. Oh, there you are. Oh, you're sideways.
Okay.
So it's this.
Okay.
Just the beauty of live, anything live.
We're going to try.
There you go. Perfect.
There we go. So
Teresa said, "Oh my, I need to hear."
Sorry about that.
I need to hear the answer. I was just reading while you were on. Okay.
So the Botox does. So for some people, like I mentioned, about 5% of people will have issues emptying their bladder. And that for those 5% of people, that's a really big deal because they have to use a catheter to completely empty until the Botox wears off. And that could be 4 weeks, it could be 8 weeks, it could be 12 weeks. It's rarely the full 6 months that it takes for the Botox to wear off, but it can be very alarming to people when they have to go down that path. It's not common, but if it happens to you, it's 100%. Well, the other thing with the infections, it's only about 10% of people, but if it happens to you, it's 100%. With the Axonics device, which also I should mention as well, there are 2 brands of this. There's Axonics and Interstim. Interstim has been out since 1997, and that's what probably a lot of people have heard more of. It's the same concepts. It's just that the Axonics is a new, updated 2020 version instead of the 1997 version we have been implanting for so long. So the Axonics, really, the main drawback to it is that it might not work for you. So we test it in the office, and about 85% of people get a great effect from the test, which tells us, okay, we can justify putting it in. Once we've put it in, it's a little battery, so you might be annoyed by how it feels. We put it in a little fat pocket, and most people don't really feel the battery that much, but you could have some annoyance there. It could get infected, but it's less than 1% of the time. You also have to charge that battery. So about once a month, you have to think about it and put this little disc, it's a contact charger over it that just charges everything up, and you sit there for 45 minutes watching your favorite show, and you're good to go for another month. So looking at them side by side, the Axonics and or Interstim have fewer side effects than Botox.
Okay. Interesting. I learned something new. I had no idea, Teresa. Just Kim says I've recommended Dr. Yes, she is. This is my Kim. Yeah, that's right. So she drives down from Marshall County, Kentucky, down here to see Dr. Allen. Okay, urinary incontinence. What did we talked about? Urgency and stress incontinence. What else do we have?
So the overflow incontinence that occurs because women are not emptying out well, that is something that also really the only thing we have to treat that type of incontinence is the pacemaker for the bladder, the Interstim or the Axonics, or a catheter. You can teach you how to catheterize yourself, which sounds absolutely nuts, but I mean, we've been putting tampons in there for a long time, you know.
Yes. Yes.
Obviously a different hole. Um, but
Yeah.
it definitely is something people can adopt and become acclimated to, and it become a normal for them. So that type of leakage is very different than the other two.
Okay. Wow. Isn't that something? What about overactive bladder, underactive bladder? What do we do? For did you see a lot of
Yes, we see a ton of overactive bladder. And again, that gets back to the lifestyle modification, decreasing the caffeine and alcohol in your diet, strengthening your pelvic floor muscles if they're not too spastic already, and then getting into possibly medications, trying at least two
okay.
medications. But overactive bladder is the same pathway as urge incontinence. You can think of overactive bladder as an
Yes.
umbrella. It covers urgency, which means you may only pee 5 times a day, but as soon as you get that notice you've got to pee, you've got to run.
Oh,
That's urinary urgency.
okay.
Urinary frequency is peeing more than 5 to 8 times a day. That is what is the textbooks say is normal. And then urge incontinence is actually losing urine when you have the urge before you can make it to the bathroom. So overactive bladder encompasses all three of those symptoms.
Okay, so everything. And then there's a combination. Some have
Mm-hmm.
urge and stress incontinence, yes? Which I think is me if I
That
were
is correct.
evaluated. Yeah.
Yeah, it's a mixed incontinence is very common, and what I start out with, especially in people with mixed incontinence, is a conversation with the people sitting in front of me, saying, this is a journey, not a destination. We're not going to do one thing and get to exactly where we need to be. We're going to have to probably try multiple things to get you happy because there's multiple problems. It's both an outlet issue and an overactive bladder issue. So
Yeah.
as long as they're willing to work with me, we usually get people pretty happy.
And I have scare intolerance, incontinence. My daughter scared me. She made her whole life mission out of scaring me and videoing it. And I don't even know she's in the house. She doesn't even live here anymore. 3 days ago, I just got dressed to go out. Had a meeting. She walked in the bathroom with her camera, scared me to death. I pissed all over myself everywhere. I was so mad. I had just put brand new pants on. I peed everywhere. I mean, I screamed and I peed. So I have scare incontinence. Terrible. And so, I was so mad at her. But anyway, there you go. I don't know. I'm just, yeah. So
I have not seen the ICD-10 code for that, but you know what? I think I could treat it.
I'm sure there might be one because there's all kinds of crazy ICD-10s in there. Like got fly by goose and all kinds of ICD-10s I've
Oh,
seen.
I know.
Oh, ridiculous. Okay, what about chronic urinary tract infections? Because I have a lot of patients, especially my age and older, as they lose the estrogen in their vagina, right? And well, all over, but the vagina is a very important place for estrogen. What about urinary tract infections? What do you see?
I sometimes joke that I'm not a urologist, I'm a UTIologist. That is
Oh,
how common it is. It is so prevalent. So when do you need to see a urologist? The rule of thumb is more than 3 infections in a year. Then it's time to see a urologist. If you're having 1 or 2 a year, you can still benefit from the information I'm about to tell you. But if you're having 3 or more a year, you need to come see us because you need an ultrasound and you need us to look inside your bladder. Now, I always tell patients the reward for going through that is often I can give you a script to treat your own infections. What's crazy about that, I think I saw you cringe a little bit there, but what's crazy about that, people actually use fewer antibiotics whenever we put them in control. So once we figure out that yes, indeed, they know when they're infected, then I give them also permission you can put off the antibiotics a couple of days. 40% of women can clear up an infection just by improving their hydration for a few days. So it is very important to stay hydrated. So the triad of everyone that comes in with recurrent infections, we make sure their estrogen is good in their vagina. Now, I'm not saying I'm going to necessarily put everyone on an oral estrogen. Not everyone is a candidate, but a vaginal estrogen or the Mona Lisa laser if they're not a candidate for vaginal estrogens, if they're in that peri to postmenopausal period. But I see people in their teenagers and
Yes.
20s who are having this problem. So it's not just an estrogen problem.
Right. Right.
So the other two big things I can't harp on enough: stay hydrated and make sure that you don't get constipated. I bring this up because so many people think they have nothing to do with each other, but you need to think of it as the bowel is loaded with bacteria, right? Normally so. We want there to be bacteria in our gut. But the problem is if you are if you're constipated, you're going to have a lot more bacteria present than you would if you weren't constipated, and it's a law of numbers. Think about if you lived next door to, I don't know, a shady crack house or something, and there was only one of those criminals that lived there, you might not get broken into. If there's 30 of them living there, you're going to get broken into at some point because they're
That's
going to
right.
get some great idea. So I know that's oversimplistic, but just don't get constipated. Do whatever you can to get rid of that. Constipation is a big issue. We've actually even correlated it with breast cancer. I know it sounds nuts, but constipation is something that should be avoided. And if you're already well hydrated, you need to make sure you're getting plenty of fiber in your diet. And if you're getting plenty of fiber in your diet, then start thinking about stool softeners and what have you. And I'm guessing that Dani probably has a few wonderful herbal remedies that do the trick on that.
A good probiotic oftentimes just
Absolutely.
constipation. I have people who haven't pooped in forever, it seems like, and they've never taken a probiotic. Their provider has never said, what about a probiotic? That's easy. Raise the water, take a probiotic when you go to bed at night. It's yes.
Yes,
I learned
brilliant.
something new. I had no idea there was a correlation between constipation and urinary tract infections. I mean, I always think about go pee after you have sex, like Louise just said, pee after you have sex. That's a big deal. I never thought about that. Hydration.
It is.
Okay.
Both of those are very important. But then, then we need to start understanding what everyone has probably that gets recurrent UTIs. They have heard probably at least once that it's E. coli. E. coli is by far the most common bacteria we see.
Number one. Yeah.
But I want to teach you a little bit about E. coli. It's not all bad, right? We want good E. coli in our gut.
We do.
And in fact, we have actually treated, and I say we, the urology community has treated spinal cord patients who were dealing with just refractory, recurrent, evil, what we call uropathogenic E. coli. We actually abbreviate it UPEC. Uropathogenic E. coli can more easily stick to the wall of the bladder. And if your gut gets chronically colonized with that uropathogenic E. coli, you're going to be more likely to get an infection no matter what you do. So the part in microbiology and E. coli science that we don't fully understand right now is how do we completely eradicate that uropathogenic E. coli from our body and replace it with good E. coli. Probiotics we know is a good place to start, but we haven't proven that we're successful at that on a consistent basis. So what we then have to do, if you are prone to E. coli infections, we tend to try to improve your immune system to be able to fight off those E. coli infections. But just to keep this in perspective, there are some patients that I've brought up, the spinal cord patients, will actually put the good E. coli into their bladder so that they don't get the bad E. coli. So that's a little extreme for someone just walking down the street who doesn't have major bladder issues. But that, just to let you know, it's not just because you have a culture showing that there's E. coli present. If you're not symptomatic, you don't necessarily need to be treated. So that's what we call asymptomatic bacteriuria, and it's something that should not be treated with antibiotics. So if you are symptomatic and you have E. coli on cultures, That's where cranberry comes into play. Now, cranberry is probably one of the most researched herbal supplements out there, and there's a lot of confusing data. There was a study that circulated on Facebook a few years ago, and they basically took a bunch of nursing home patients who did not drink like they should, did not poop like they should, and did not use estrogen, and they tried to give them cranberry alone, and it didn't make any difference. Of course it didn't make any difference. They didn't get the magical triad under control first. But once you have those other issues under control and you're having E. coli infections, a high quality cranberry supplement can be very beneficial. Now, high quality is the key. The cheapest way to make cranberry supplements is to take a big vat of cranberries, dehydrate them, crush them into powder, and put them into a capsule. Unfortunately, the proanthocyanidins, the active compounds in cranberry, are not available to our body if they come from the pulp of the berry. So they have to come from the juice of the berry. So that is what makes a good cranberry supplement, and I dare you to find that information on any bottle out there. It's very tough to figure out what's good and what's bad, but I will tell you, if you go to Costco and you see a bottle of cranberry, 180 pills for $7.99, it is not a high quality product, and you're wasting your time. So,
he's preaching to the choir over here. They hear me say this stuff all the time.
I love it.
About that. Yes, yes.
So, we recommend Theracran and Allura a lot, but if people are working with someone, a provider who recommends supplements to them and they know that is a high quality supplement, go for it. But just don't waste your time on the crap that's in the grocery store and the drugstore.
Yeah, we use UT Max in the office. It is unbelievable. Hot, really amazing cranberry. It's got D-mannose in it. It's got some D-mannose in it, and it's got several things in it. It's the only thing that I use for urinary tract infections there, and it's phenomenal. So I am so glad to hear you say that. But I learned that. I learned something about the juice of the cranberry. I've learned so much tonight. These people are going crazy over here. They're all, holy cow. Okay, so actually Louise is saying, can bladder spasms be minimized by cranberry without sugar? Yeah.
So I have seen people who have overactive bladder improve with cranberry. So I've to figure this out, I've extrapolated in my brain a few studies. There was a good study done several years back that actually showed that people with a normal bladder function, meaning they pee 5 to 8 times per day, they don't have any urgency, they don't have any leakage. That's what we say is normal. Will have about 25 to 30 different bacteria in their urine just when on random spot check. Our urine is not sterile, which is why I said do not drink it. So the people who have overactive bladder have about 50 different species of bacteria in their bladder. So I do occasionally run across people who say that their cranberry helps with their bladder spasms and it helps with their overactive bladder. And my theory is that they have like this undertone of just an amount of bacteria that keeps their bladder irritated, but isn't quite drastic enough to cause a full-fledged infection. So it's worth a try. If you try it and it helps, great. If it doesn't help, then it's hard for me to recommend staying on it.
Good answer right there. Man, I wish I'd had you on years ago. What about interstitial cystitis? What about that? That's a hard one for me with patients. And of course, I don't treat it, but my entire practice is based on decreasing inflammation in the body from the head to the toe. And anything that ends in itis, which thyroiditis is the bulk of my practice, but cystitis, vasculitis, arthritis, gastritis, sinusitis, it's all inflammation. So that's how I work with it, because clearly I'm not a urologist. What do you see in the office? What do you do for these patients? Because that's a hard one.
It is absolutely a hard one. And we break it down into really 2 categories. There's interstitial cystitis with Hunner's ulcers, and there's interstitial cystitis without Hunner's ulcers. Now, so the 10% of people with Hunner's, Hunner apostrophe
They
S.
missed that one in nurse
These,
practitioner school for me. I never heard of that in my life.
so these are abrasions in the bladder that sometimes can't necessarily be readily seen when we first enter the bladder, but we might be able to identify them after we have distended the bladder. A lot of times we do that under anesthesia to identify those areas of ulceration. But it's sometimes a fibrotic appearance. There'll be a little band in the bladder, and then there's areas where the bladder lining has actually sloughed off, and we're actually seeing an ulcer. So
Wow.
those people have what we call urothelial dysfunction, like the actual lining of their bladder is a major issue. The other 90% of people, the urothelium is not an issue. And crazily enough, it has more to do with their muscles and their nerves, even though they can completely identify the problem as being a bladder problem because that's where it hurts. They may say, my urethra burns, the tip of my urethra burns, my bladder is spasming. A lot of times it has to do with overactive nerves. And I sometimes explain it as a fibromyalgia of the bladder. And it's, just as, even though with fibromyalgia, we don't have an x-ray that shows it. We don't have a scope that shows it. We have to make it a diagnosis based upon symptoms. That's the same way with IC, which is what makes it in those 90% of people that don't have ulcers, that don't have blood in their urine, it makes them feel like they're crazy because nobody can find anything wrong. When in reality, it is a dysfunction of the nerves that needs to be regulated. Now, you hit the nail on the head. It is inflammation. And I wish to God I could send every patient to you and you could get them deflamed, and then I'll just take the leftovers. Because if you're walking around with all these cells, which we know fat cells alone are inflammatory, if you're drinking 6 colas a day, which the acid in those colas and the low pH causes this inflammatory state. I can't fix that until you cooperate. But I do come across people who feel like they're doing everything they can possibly do. And for those of you out there, I didn't really elaborate on what is interstitial cystitis. The layman's term for this is chronic bladder pain syndrome. And the fact of the matter is they feel exactly like they have an infection, but there's no bacteria. So they have this inflammatory response that feels terrible, and they could wake up with it and go to bed with it and wake up all during the night with it. So it can be a large continuum of symptoms. It could be as simple as I have a flare every fall, because we do know allergies play a role as well. Some people have a flare with stress. Some people have flares after a urinary tract infection. So that's how we describe it, these flare-ups. And then some people live with a flare. And the nice thing about where we are with treatment of interstitial cystitis now is the American Urologic Association does have an algorithm of how this should be treated. And it's step 1, step 2, step 5, step 6. And essentially, if you are seeing a urologist, hopefully they are following that algorithm. But we start with stress management and diet management, because again, we had talked about those bladder triggers before. Spicy foods, caffeine, alcohol, and acidic foods can be very annoying to the bladders of these people. So you eliminate those things. And I usually encourage people, after you've eliminated, start adding back what matters to you to see if it's a trigger for you. It may not be. And I don't need you to add to your stress. I don't need you to add this weird diet that you've got to stay on. But if you figure out things that do trigger your bladder, stay off of them. That's an easy decision.
Yeah,
So
absolutely.
then we look at, we treat with antihistamines. There's antidepressants that can actually help. There are my favorite, which I promise I'm not just catering to you, Dani. My favorite is aloe vera. Aloe vera is amazing. Now, here's the thing about aloe vera. You actually have to have the anthraquinones extracted so that it's not a laxative. You don't want to take pure aloe vera or whole leaf aloe vera, because it doesn't have the anthraquinones extracted, and it's going to be a laxative, and that's not good for your gut. But there is the company that I use the most is and has done the research on this is desertharvest.com. And Desert Harvest they have a lot of white papers on there if you want to read about it. They also now have a CBD oil that's infused with one of their aloe vera supplements that they are getting great improvements from. So that's one of my favorites. I use that more than I do the only FDA indicated drug for IC, which is Elmoron. Elmoron it works for about 30% of people. It can cause your hair to fall out. 4% of people will have hair loss. Most people will have dry skin. It's a blood thinner. So there's a lot of kind of not so great things about Elmoron. But for 30% of people that have IC, they say, oh my God, this medicine is amazing. So for those people, maybe we get to that point, but it's definitely not my first line of therapy. But weirdly enough, antihistamines, including the H2 blockers that we use for reflux, like cimetidine, that's
Yeah.
part of our treatment for IC. So, but you can, we do have that algorithm. After the medications haven't worked, then we think of bladder stretching, where we actually take you to the operating room, stretch the bladder. We actually cauterize any ulcers that we might see. And in some people, if those ulcers keep coming back, we'll actually inject the ulcers with steroids to stop them. And that can be a godsend to people. Once we've tried the hydrodistension, then we think about Botox and the pacemaker for the bladder. Again, we are working on the nerves, and this is a nerve problem. So both of those can be effective. We actually can use fifth line therapy is cyclosporin A, which is a immunosuppressant that people get put on who have organ transplants. Now, by the time they get to cyclosporin A, they are bad, and they have tried everything, and they are on the verge of saying, please take my bladder out, which is step 6. We take people's bladders out for this disease process. It is not common, but when we have people who just are refractory to all other treatments, then we do sometimes get to that point. So it's the real deal, but the good news is most people are controlled within the first 2 steps of that treatment algorithm, and they don't come anywhere near 5 or 6.
Whoa. That's a lot. I tell you what, guys, these people are going crazy on here. This is fabulous. Has this not been amazing, guys? Show her some love right now. I mean, yes, we've covered it. We talked about kidney stones. We didn't, I mean, what else? I don't know. I mean, there's way more. No, there's vaginal rejuvenation.
Rejuvenation, the fun stuff.
That's for life, the fun stuff. Yeah. What about it? What do you all offer?
Okay, so we joke, we purposefully named our group Female Urology of Nashville because we're fun, and
Yes.
and so we get to use that acronym on everything, and it looks good on shirts and hats. So, but it is truly, it's been the science of female sexual health has been a long neglected area. And
Yes.
about 10, 15 years ago, the plastic surgeons started paying attention to it because nobody else was. Now, as urologists, we were trained, from, the very first day of training, we started talking about men's sexual health, and we knew all about Viagra and Cialis and Levitra, and we knew all about, I learned how I could do a penile implant in 22 minutes. So when the medicines quit working, we can put this into the penis and make it work. We had all these solutions for men, and nobody was even talking about the women for so long. And it's been amazing just in the last really 10 years, just since I've been out of residency, we have really seen that entire arena change a lot. Now, again, the plastic surgeons are focusing on it. And yes, there is an aesthetic component. A lot of women who have maybe very large labia don't like their appearance, and we do labiaplasties. There are some ladies who they're like, I don't care how it looks. I don't like the way I feel down there. I don't feel as tight as I used to be. And I've done all the Kegels I can possibly do. What else can be done? Well, like I mentioned before with the leakage, collagen plays a role with this. So we have a treatment called the Forma V made by Votiva that's radio frequency energy delivered to the tissues that bulks up those tissues. So if you'll start following Votiva or Forma V on Instagram, they always post the greatest little pictures. Today, the picture was a scrunchie. I know we all wore scrunchies at one point, and they're coming back in, which is insane. So imagine a real stretched out scrunchie. They had one sitting right next to one that was nice and tight.
That's funny.
So we can't post our before and after pictures, but it is a significant result. People do really appreciate the improvement in sensation, the improvement in blood flow, because then that helps with orgasm, the improvement in nerve function. So there are many elements that in the body that this improves, and it is radio frequency, very safe, doesn't hurt. I mean, it's just one of those things. People are very surprised at how easy this process is. It is 3 treatments. Did you? Good.
But not with you, but I need to go to you now because it was with somebody who it was brand new for them, and I was a test person and all that. And
I love it.
But that's been 2 years ago, and I didn't go back for my whatever. But I'm going to tell you, it worked. Now it's I don't know how long it lasts, but it's time for an refresher, or whatever you call it. But it did work. Votiva, yes, Votiva, and I think it did not hurt at all.
Exactly.
I have a friend of mine who did laser, and that hurt. I mean, it got hot. It got hot, I should say.
And to clarify, so if the laser is done well, in which we do in our office, it is the physicians doing the laser. Right. So we actually don't have a nurse practitioner right now. We are open to the idea of it, but for right now, it is us doing the laser. And when we numb up properly the external area, you don't feel a thing. But if it's not completely numb, then yes, you will feel some discomfort with that laser. Now, people say, well, why do you have both the laser and radio frequency? Why do I need both? Well, the radio frequency is more of the deeper tissues that aren't necessarily estrogen dependent. So the 35 just got finished having 3 kids, and it's like, I just don't feel like I used to. Forma V or Votiva is her answer. The person who comes in and their only complaint is, you know what, I'm super dry. It hurts a little bit with sex. I may have started having a little bit of leakage or a little bit of urgency, but I don't necessarily feel loose. In fact, sometimes it feels too tight because as you get less estrogen in that area, that skin tends to tighten up and it's not as flexible. Those people are best treated with the laser because the laser penetrates to a depth of 0.5 millimeter, and the radio frequency penetrates to that 3 to 5 millimeter depth. Now, I do have some patients who do want both. And you can have both. So it's different things that we're treating. There's a nuance to choosing what is best for you. So as far as other things that we have the O shot that was it's been all over mass media. The O shot does help with clitoral sensitivity. It's platelet-rich plasma, so we draw your blood. We draw 20 cc's of your blood. We spin it down with a special centrifuge to basically get the 20 cc's down to just 5 cc's of platelet-rich plasma, which is very healing. You guys may have heard of the vampire facial. Same guy invented both of these products or both of these applications.
Facial. Yeah, I've had that done, but I didn't know it was the same.
So Charles Runnels is his name. He's down in Alabama. Very interesting guy. But he basically figured out if you inject this into both everyone's cringing right now. Again, it's all about the numbing job. And we have this amazing numbing medicine. Most people are just sitting there chatting with me as I do it. It is not painful. So we inject there. And then also the area right around where the urethra meets the bladder. That area has traditionally been kind of called the G spot because Dr. Grafenberg described this area of heightened sensitivity. It is an area of heightened sensitivity for a lot of women, but it's really more about more blood flow and more nerve endings because the bladder neck is right there. And sometimes that translates to a really good feeling. It's not like the G spot is a special organ. It's not a special gland. It's not an identifiable object on MRI. It is part of our body. It's just a way to describe a really sensitive area in our body. So we inject it into that area as well. This platelet-rich plasma will, again, stimulate blood flow, stimulate new nerve formation, and so it does improve sensitivity and can help people with orgasm. So cool stuff that we have.
Wow. Unbelievable, guy. I just put their information up there on the screen. So you guys need to take a picture of it and give them a call. Yeah, it's phenomenal what all you do. So they can get, I learned so much. I'm going to tell you, the aloe vera and the interstitial cystitis, that is mind blowing to me. I had no idea. And so I've posted everything, guys. You guys can go back and watch it. What else? We know how we can get in touch with you. That's the correct phone number, isn't it? 5544?
678-5544. Yes.
Got it. Okay, perfect. And then what else? Anything else, guys? I know we ran over. I'm sorry, people, but you all were so active here. Yeah. You have 1,000 hearts going up.
Oh, I love it. Well, one thing I would like to interject. Something that women can sometimes ignore that you don't need to is blood in your urine.
Yes, I have it on my list.
Okay, yay. So especially painless blood in your urine. That is actually way more worrisome than blood in your urine when you actually feel like you have an infection. That's a common reason to have blood in your urine when you're infected. But if you're not infected and you're seeing blood in the toilet and you know it's coming from your bladder, you need to be checked out. That's never normal. Even if, you might get, if you're still having your cycles, you might spot between cycles. If you can't figure out, well, did that come from my vagina or did that come from my bladder? Stick a tampon in. And if you have blood on the tampon, then it came from your vagina more than likely. But if that tampon is clean, it probably came from your bladder and you need to be checked out. Now, hopefully when we check you out, we will find something like a kidney stone, or we'll find, a kidney that may be not draining appropriately. But sometimes we do find cancers in that situation. And so when anyone has blood in their urine, the workup is imaging with either an ultrasound or CT scan, depending on the amount of blood. And then we also take a look inside the bladder with a scope. It's like 2 minutes of a catheter. It's not that bad. When we get done, people are like, "You're finished already?" It's nothing like a colonoscope. But it answers the question of, is this something to worry about? So we're so used to seeing blood in the toilet because of our periods that especially when you're postmenopausal, never ignore it. Always address it with your physician, and feel free to call us if you don't have somebody that on close standby that you can talk to about it.
You bet. Postmenopausal bleeding is never normal. Never. And I mean, I've got them out of that office. I mean, it's just not normal. It should not happen. And especially if you don't have a uterus. I mean, people come in and it never clicks with them, right? That, okay, well, this isn't the uterus bleeding over here. I don't even have a uterus. So postmenopausal bleeding is not ever normal. So always something. I'm glad you brought that up. So I thank you so much for being on here. Oh my goodness. And there's a lot of questions on here. So this will be on our Facebook and it'll be on yours.
Okay.
You won't hear it on yours, because I appreciate you so much for being on here. And guys, next Sunday night, we're not going to have Sunday night service next week, first time in forever, because it's my daughter's birthday and I'm going to be out with her for her birthday. So it's Ella's birthday and I'm going to be celebrating her birthday. But on October the 18th, Brenda Dixon, who is a, good Lord, psychotherapist. That's a terrible name, actually. Psychotherapist. I mean, she's a psychotherapist. She is going to be talking on anxiety, and the anxiety, that's her specialty, is anxiety. And the anxiety that we've seen just bubble to the top in 2020 that patients are going through. I mean, anxiety is huge right now. So October 18th, Brenda Dixon's going to be on here talking about anxiety and what she does for anxiety with her clients. And also that's going to be very exciting. Also want you to know, I want you all to post up here. Who do you all want to hear from? Because, you know, I've been doing this every Sunday, basically for 3 years. I need some new people on here. Like we got Dr. Allen on here tonight, but give me your topics. Tell me what you want to learn about. I mean, we whatever you want. I don't care who you want me to ask. I'll ask them, because the answer is always no if you don't ask. And if you do ask, you just might get a yes. So no request is too crazy. Let me know who you want to hear from and what you want to talk about, and I will do my best to get somebody on here or do it myself. Okay. So I appreciate you guys. You all have a fabulous week. Listen to what she said. Inflammation. I know, she knows this. We know this. This is clinically proven. Every single chronic lifestyle disease that is out there. And lifestyle diseases are diseases you weren't born with, which, by the way, you weren't born with most diseases. Now, there are some people who are born sick. Most people were not born sick. We know that the root of 100% of all chronic lifestyle diseases is inflammation. And inflammation, 99.9% of the time, that's my own number, I don't know for sure, stems from what's at the end of your fork. So what's at the end of your fork is way more powerful than what's at the bottom of your pill bottle. Say that's a pill bottle. So if you don't decrease inflammation, you will never get to the root of the problem she's talking about, of the autoimmune disease, of the high blood pressure, the anxiety, the depression, the diabetes, you name it. Decrease the inflammation and your body starts to heal. She knows this. She and I are not hurting for patients. We've got plenty of patients. I would be happy to have a few less patients if you all would work on the inflammatory process in your body. It's the key. Do you agree?
Absolutely. No doubt about it.
It's the key. You can go see all the people you want, but until you fix the root cause of every bit of this, right? I mean, we're just chasing our tail over here. Sorry. I know. I appreciate you. Thank you so much. Kimberly says, thank you, Dani, for inviting my doctor. Oh my goodness.
Good to see you.
Oh, that's a good way to end it, Kim. All right, don't go anywhere. I'm going to end this, and you don't go anywhere, Dr. Allen. All right,
yes,
you guys,
ma'am.
Get ready. Meal prep for the week.